Thank you. The causes of strokes during carotid stenting is mainly atheroembolic. And these could be various issues: access, filter navigation, passing of protection devices, aortic arch disease, hypertension, atrial fibrillation, and air embolism. With embolic protection devices, there's no level 1 support, and clearly that is the issue. It's still class 2 with a level of evidence C, and there's no randomized trials, large randomized trials assessing the impact of EPD on embolic protection devices on clinical outcomes. But there are now comparative retrospective analysis and some small trials comparing head-to-head of various types of devices. Now, the most important thing is that the large trials now which showing with high-risk patients with various devices showing clear-cut better outcomes, and most outcomes are less than 3%, and many of the very good trials showing less than 2% in terms of outcomes in terms of these high-risk patients. The other problem is that embolic protection devices have been used very, very inconsistently in many trials. You can see from 27% to 95% in the CREST. So clearly, embolic protection devices, like we've had the discussion in the morning, are not very clear whether we should use it in all patients. Is it mandatory? Well, we know clearly it's better to use it, but is it an absolute must is still an issue in all patients. Now, when you use cerebral protection devices, you have three types, and that is one is the distal occlusion device, which is the Percocet guide wire, the Kensi device, and the Minavis's device. You have the distal filters, various filters will go through, and the proximal occlusion devices, which is basically the MoMA and the Gore device. The distal filter device is simply you put a filter up the internal carotid artery so that nothing goes through. The blockage device, you just block the vessel so that no more particles go through. Flow reversals are two types. One is by proximal blockage and ECA occlusion, which is the MoMA device, and the Gore device, which is basically the flow reversal device. Each of these devices are a little different. You should know about it. This is the Boston Scientific filter. It is a 3.2 French device. It fits only 3.5 to 5.5 millimeter vessels. It's preloaded with a 110 micron spore. The Spider is a very useful device because you can parallelly pass a coronary wire of 1/4. It's preloaded filter and 6 French compatible. The Amber Shield is easily talkable. It's a bare wire, very low profile, and good circumferential radiopacity. The AccuNet is again flexible. It's easy to capture and control, and it's a very good device too. There are very other filters, the AngioGuard, and all of these have different landing zones, different profiles, different French, and we should be very useful. And I would request people who do carotid stenting to stick to 2 or 3 filters maximum if you're using them, so that you learn the nuances of the filter and do it very, very usefully in most of our patients. Obviously, this has been discussed, the 3D filter, which is the FiberNet, which is a very good device because it's novel, because it captures very, very small particles, and it also conforms to asymmetric vessels and very, very tortuous vessels. So these are the comparative crossing files of the distal filters, and you can see that they range from 2.8 French to about 3.7 to 3.8. They can be taken by 6 French and 7 French, and I would again request you to put this up in your cath lab when you start doing these procedures. The FiberNet is really possibly the lowest crossing profile, and it's just 1.75 inch and a 2.9 French device. So it's really one of the very good devices in patients who can use it. But in this country, it's a little more expensive when most of it decides. The other thing is the landing zone. You should know these filters because the landing zones are different. And if you don't have an adequate landing zone, you will get into trouble. So you need to know these filters very, very clearly. How much of landing zone do you get? The distal embolic filters also have pore sizes, and they could vary from 150 to 110. And these are important because if your pore size is 100 microns or lesser, the major stroke rates are much lower than if your pore sizes are larger, because the small particles get captured by the smaller pore size. So distal embolic protection device, if I have to summarize, they preserve antegrade flow, contrast imaging is possible, it's a faster procedure, avoids external carotid cannulations, more flexible. Disadvantage is does not capture all debris. It may clog, cause spasm. The delivery catheter itself may cause embolization. A retrieval sheath, where if you don't be careful, you can snag in the stent. And sometimes, in tortuous anatomies, the filter itself, when you put it in, can create an embolization. Important, never advance filter without good target ACTs. Hold the wire steady during the divide exchange. Minimize filter movement to prevent spasm dissection. I've seen filters moving up and down in the carotid. That creates a problem. Always keep your eye on the filter to prevent it being pulled into the stent. And when a buddy wire is used, make sure the wire you're removing is the buddy wire and not the filter wire. You look for spasm, look for filter slow flow. Don't panic when there is muck in the filter. Just pull it back. Don't hurry the procedure, and that's when sometimes the filter gets caught in the stent. And don't allow the filter to migrate into the bend so that it does not create spasm. Keep the two hebos open, and sometimes good two hebos is important so that neither you get an air embolism and all the blood bleeding from the guiding catheter comes throughout. Potential filter issues are wire kinks, filter jamming in the filter sheath, in the delivery sheath, filter losing its shape, and filter detachment. And very, very importantly, we should be very quick in these procedures. So this is a typical stenting done for a right internal carotid artery. So you put a filter up right there. You can see the filter right up there. You put a gazelle balloon, predilate it. You put a carotid valve stent. Finish off the procedure with a nice, easy result. You can do it bilaterally. Many of our patients, we are now doing it pre-surgically bilaterally. Sometimes I stage it, sometimes I don't. But you can do it very quickly. And the same filter, the advantage if you do it at the same time, you can use the same filter at the same time. Some people are a little concerned about the issues of neural issues due to bilateral stenting at the same time, but in our experience, it's not been a big issue. So you can put the filters, the same filter on both sides, and finish off with two stents and get a very nice result with both side stents. As I said, there are issues with detachment, there are issues with slow flow and occlusion, and hence you have the PercuSurge, which is a very good device. And this is the PercuSurge being put in a very nasty lesion. But the problem really is that the PercuSurge blocks the flow completely, and some of the patients don't tolerate it when you're putting the stent through. But again, it acts very, very well if the patients tolerate it, and there's really no distal embolization in patients. So once the whole issue is that distal EPDs have their limitations, which we can overcome by proximal devices, but the real concern is that you need to be very, very large fringe catheters, and you need to be very, very operator friendly with these patients with the proximal filter. These are devices which are the two types which we have just talked about. One is a GO device and one is the MoMA device. And one has got a reversal system and one is a blocking system both proximally and distally. So you need, in the MoMA, which is the more popular one in India, you have two anchoring balloons, and the advantage clearly is achieve cerebral protection, but does not require the landing zone of EPDs, maybe having better results shown in the CAS trials today. And it's important that you have a good external carotid artery. For the disadvantage is more cumbersome, and imaging with a stagnant contrast is an issue. There are very few trials comparing proximal versus distal. There's a small trial showing basically that proximal balloon occlusion can reduce the embolic load to brain, but these are all small trials, and we'd not like to conclude by these issues. I will stop here for the paucity of time, but we have in our hospital currently about patients who've had filter devices of about and protection devices of 162 patients with unilateral and bilateral stenting. I won't go through it, but in conclusion, I think there's a space for both these devices, proximal and distal. Distal are much easier to use, more user-friendly, but again, there's a scope for improvement of these filter devices so that you get adequate protection when you do a good carotid stenting. Thank you very much for your patient hearing.
Thank you.